Hi, everyone. It's good to see everyone. Just wanted to take this opportunity to welcome everyone to the 2020 Occasional Temperament Conference, all from our own living rooms. We're excited to open our virtual conference and hear all of the latest and greatest about research and clinical practice on temperament. So what a time we've had for our OTC 2020. First a global pandemic, then our event this Sunday and Monday coincides with Halloween, daylight savings time, a full moon, and Martha Ann pointed out to me, not just a full moon, a blue moon too. And you know, that pesky little thing of a presidential election in the US. So that's quite a list. So I appreciate everyone taking a break from it all and joining us for OTC 2020. I'd like to start out by thanking my colleague and co-organizer, Dr. Martha Ann Bell, and the support provided by Virginia Tech's Continuing and Professional Education. We wish we could host you all here in person, but we are going to have a great virtual conference and are looking forward to the exciting things that are going to be presented in all of the symposium and in the poster sessions later today. I just want to give a special shout out to Diana Devine. I think you all now have heard from her repeatedly, and she is our grad student extraordinaire. Conference organizer is too small of a title for her based on everything that she has done. I also wanted you to all know that she is a researcher in her own right, and she would have been presenting today, but we decided that she would probably be a little too busy on the day of the conference. But so that everybody can put a face to the name, this is Diana. She's been invaluable to us in carrying out this conference. When I asked Diana if she was interested in helping us plan and organize the conference, she jumped at the opportunity to have this professional development experience. None of us knew at that time how our conference planning would develop over time. Diana has faced every challenge with grace, and we seriously could not have organized the conference without her. I would also like to acknowledge my department, who provided funding to allow Diana the time to support to OTC. Diana has worked tirelessly, often behind the scenes, from the beginning of the planning till now. Thank you so much, Diana. We are also very grateful to the sponsors that help support this conference. These are all from Virginia Tech, my department, the Department of Human Development and Family Science, Martha Ann's department, the Department of Psychology, College of Liberal Arts and Human Sciences, the College of Science, and the Institute for Society, Culture, and the Environment. Without these sponsors, we would not have been able to have the discounted rate for the graduate students and early career scholars, and we really felt that we wanted to encourage their participation in our conference. And so we are so pleased that our sponsors were willing to help us meet that goal. Finally, thank you to all of our presenters and attendees. Thank you for your patience and understanding through all of these changes and the new ways of hosting events that are necessary these days. I'd now like to introduce Dr. Sean Mcdevitt, who organized our symposium honoring the contributions of William Carey. While it's sad that Bill cannot be with us anymore, I'm happy that he knew about our plans for this symposium in his honor. And I'll now turn it over to you, Sean.
Thank you, Cindy. First of all, I want to congratulate the organizers of this meeting, Cindy Smith, Martha Ann Bell, and Diana Devine, on their incredible adaptability, moving the meeting dates from March to November and then shifting from in-person to virtual formats. This was an enormous undertaking, and the very fact that we're here today is testimony to their dedication and persistence. So thank you. I was very pleased to be asked to chair a symposium honoring Bill Carey and his study of temperament. As the symposium was envisioned pre-pandemic, we had hoped that Bill could attend today's presentation and feel a sense of recognition for the accomplishments in his life work. Unfortunately, that was not possible, so now the tribute will be virtual and posthumous. Bill died on July 26th of this year at the age of 93. Another regret is that we were unable to do a podcast with Bill about his lifetime of working with temperament. I had been talking with fellow TC member Lori Haynes to set this up before Bill passed away, but could not get it arranged in time. Lori and her colleagues at Iowa State have been doing parenting podcasts for the past few seasons, and we had planned to do a podcast about Bill's career. At this point, it appears the best we can do is a podcast with me about working with Bill. Stay tuned for that and possibly other podcasting in the future. The group of professionals presenting today represent work done to apply temperament concepts to individuals and families. This enterprise is fundamentally different from work that's directed toward understanding the concepts themselves. Understanding people is different than understanding ideas. As you will see, the presenters represent different backgrounds and different approaches to temperament that mirror the multifaceted clinical fields and varied settings where temperament applications take place. Although Bill is not directly involved in their work, his spirit can be felt in their contributions. Our first presenter today is Bob Hudson. Bob's clinical professor of pediatrics, University of Oklahoma in Tulsa, now retired. He's the author of the 2019 book, The Normal But Not So Easy Child. Dr. Bob, as he's known to his patients, practiced general pediatrics for 25 years and behavioral pediatrics for 16. He ventured into research in the last years before his retirement and continues to write. I'll turn it over now to Dr. Bob.
Thanks, Sean. I appreciate that very much. And the honor of giving a tribute to Bill. And his 5 decades of temperament traits, and his contribution to us in ideas and in the way he helped parents primarily. He taught residents and students, and primarily, I'm also a pediatrician. He taught the pediatricians, and he certainly did research. He wrote a book, and he made friends very easily. He was a very kind man. As we all start research for these presentations, we go to Google. I Googled William Carey, and up pops missionary to India, 19th century. Well, Bill was a type of missionary too, a missionary for temperament. And his life turned in 1968, as he said in his tribute to Alex Thomas. He left Philadelphia, went to New York City to pitch Stella Chess and Alexander Thomas on his simplified questionnaire to facilitate parental reporting. That hit a home run. As we all know, the rest is history. The Carey scale was born. 1968 was a seminal year for me too. I was chief resident, whose job was to tote and to tour and to run the PowerPoint presentations. We called them slideshows back then for Stella Chess that day. She was visiting and reporting on the first 10 years of the 30-year New York longitudinal study. That changed my life and gave me a new passion. As Sir Michael Rutter said, the mark of greatness in any idea is found not in the extent to which it proves the details, but rather the extent to which it fosters new research that carries the field forward. That was said of Stella Chess and Alexander Thomas, but it could be said of Bill too. He started a new understanding of pediatrics and changed the clinical practice by helping parents. That was sort of pediatricians before sort of, oh, that's sort of normal behavior. Let's see you next year. But Bill saw their suffering and wanted to help and focused on that help through explaining temperament to the families. He collaborated, as we all know, for the research in clinical practice and also in research with developing the Carey scales. 1995, he wrote the Coping with Children's Temperament, which was a guide to professionals. He questioned the way we thought, we practiced, and we did research. His honors are way too numerous to count. In understanding the magnitude of what he changed, we have to really look at what was going on from the 40s to the 60s, and unfortunately even now. The environment, and in particular the child's mother, was responsible for all their child development, behavior, and any problem that arose emotionally. Quite a burden for moms. Without much help from pediatricians, until Bill came along and he said to all of us in various formats, if you don't use temperament in your clinical practice, you're developmentally delayed. Sounds like Bill, doesn't it? The medical establishment operated a disease model. One variable, you either have something or you don't have something. You either have a strep throat or you don't have a strep throat. You don't have a little bit of a strep throat or a lot of a strep throat, you either have it or not. A light switch, one variable model is what I call it. The mental health model doesn't fit that. It's much more complex in both degree, complexity, and amplitude. We have an amplitude in mental health that you don't have in medicine, which was a real attitude to overcome for pediatricians, which is usually the first stop that parents make. The mental health model I look at is much more equivalent to a rheostat. It's much more flexible and compatible with fitting complex models. Bill understood this, and his dispute with the diagnosis of ADHD perfectly illustrates the complex and varied set of symptoms that's been forced into an arbitrary set, rigid set of criteria to make the diagnosis of ADHD. So now what? What's the new direction? Well, Bill gave us a clue in his disagreement with the whole attitude of ADHD and the whole diagnosis criteria. He made the statement in his Temperament and the Pediatrician paper, ADHD diagnosis is due a major overhaul. And I think that what he was saying was we need to start looking at it in a different way. In his chapter, The Attention Deficit Disorder, the State of Science, is ADHD a valid diagnosis? How do we get there? He makes the points that ADHD is really the poster child for ambiguity because it's so arbitrary, ill-defined, and subjective, and much more complex than the medical model allows it. But in my experience with ADHD has reinforced that it's sort of a wastebasket term of anything behavior or learning gets thrown into the ADHD diagnosis, even if it doesn't fit the criteria. Then we hang it as a comorbidity. Oh, they have oppositional defiant disorder. Oh, well, that's just a comorbidity of ADHD. Sort of like saying 20% of people have blonde hair, so 20% of ADHD, it's a comorbidity of ADHD. It makes about as much sense. It's different. It doesn't fit within that diagnosis. So there are some that says, how about integrating temperament traits and executive functions? We know now much more about executive functions, and how does that provide an advantage? Well, temperament traits are genetic components, and executive functions are skills that evolve into problem solving. Temperament traits don't have inhibitory control or working memory, which is a real set back and understanding this complex area. And it does for other mental health diagnoses. The hot executive functions, the ones that are for behavior and emotion, lack a social emotional construct. They talk about it all the time. So temperament traits do have sensory threshold and mood. So intervention and treatments usually begin by altering the process. It's component dependent. You don't start at the end and say, okay, we're going to change self-regulation. You say, why, what portions of self-regulation is the skill weak, and how can we help it? Is it adaptability? What? So here's a proposed new executive function model that integrates both. Hot executive functions, cool executive functions, with inhibitory control really straddling both, because it's necessary to start either process of problem solving, whether it's emotional, whether it's behavioral, or whether it's learning. So we've placed the temperament traits that drive behavior and emotion, adaptability, approach withdrawal, sensory threshold, and mood within the hot executive function. I've sort of given up on cool executive functions because the temperament traits really don't have working memory. They don't have the planning and organizing and all. They have things that hint toward that, but don't really measure it as well. So this is the proposed new model. If you compare the behavioral temperament traits and the hot executive functions, the ability to switch and adapt, what is that? It's adaptability. It's a response to change. If you're talking about attention, switching, and flexibility, and is it change or is it new? How do you incorporate a new experience into cognitive flexibility? So these are two components that fit well. Emotional control with executive function is much more ill-defined. But if you add sensory threshold, which is the really boils down in solving social problems, how am I reading others' emotional content? And how do I solve its social emotional problem? And the mood is, do you start off positive? Oh yeah, this is gonna work, or this is never gonna work. So those are important in this piece. So the advantages of integrating temperament traits with executive functions, it expands our assessment question data points. It's more specific. It adds data points for social emotional assessment that are not there without the temperament traits. It adds the first step in the response. How do you respond to change? How do you respond to something new? How are you reading the information that you're getting? And it adds a metric as a standard deviation from the mean and adds the amplitude. As we all know in clinical behavioral health, the amplitude matters. The difference between a 1 standard deviation non-adaptive child is much different than a 3 standard deviation non-adaptive child. It allows the less trained second party or parties versus the one-on-one assessment, so it saves time and money. So much of executive function is done by one-on-one assessments. But with the research that I'm going to show that we've used this model with, we were able to use teachers as less trained. And so we got a much bigger sample. We did both studies for about $1,000, if you can believe that. Study 1 was predicting behavior and learning issues in a suburban pre-K classroom. We assessed 1,100 students the 6th week of preschool and followed them for a year. The assessments identified which students would have difficulties with behavior and or learning, and that correlated at the end of the year. 43% had at-risk behavior of 1 standard deviation or above, or a learning issue. The students identified as at risk be able to imbalance within a classroom because they did no mental health screening or no behavioral screening, ranged from 10% at risk in a classroom to 55% at risk in a classroom. Which classroom would you rather teach? So we developed and validated a 1-minute screening tool that the parents filled out before school started. It was called the Not So Easy Scale and was based on disruptive behavior in a set period of time. Did they have a meltdown, once a month, once a week, once a day, or 6 times a day? Much different, the amplitude again. Study 2 was the differences of temperament traits and executive functions, urban, mid, high, mid, and low performing kindergarten classrooms. So it was a large school district. We took 450 students in both high, medium, and low scoring achieving classrooms. 1 standard deviation in the high risk showed 38% at risk. But if you go to the low performing school, it was 77%. And even more disturbing really was that students with 2 standard deviations at risk for temperament traits and executive function had only 9% of the children had 2 standard deviations. But in the low scoring classrooms, it was 55%. So low to high classrooms corresponded to middle, upper middle class, and the high performing to lower socioeconomic and the low performing classes. The hot executive functions took total precedent over the cool executive functions in the low performing classrooms. Just getting started learning required that you had some kind of classroom calm, and that was certainly not the case with the lower performing schools. Thank you, guys.
Thank you, Bob. That was quite interesting. I think your work on executive functions has been really valuable. Our next presenters are Sara Harkness and Charlie Super from the University of Connecticut. They're both long-term members of the temperament community, known for their extensive cross-cultural research on temperament and how its importance and expression are affected by different cultural settings. Sara and Charlie?
Hi, everybody from snowy Northeast Connecticut. We are looking for our PowerPoint presentation, which I think will take a little less time than Dr. Bob's, sorry. So we want to just talk a little bit about the internationalization of temperament research as part of a tribute to Bill Carey. So, enter, okay. So, of course, the story of Bill Carey and, of course, Sean Mcdevitt's work really starts with Alex Thomas and Stella Chess, who are pictured here at an OTC 2000 that some of you may remember in Mystic, Connecticut. Bill Carey was inspired by their concepts of individual differences in child temperament and their implications for pediatric practice. So I just put in a couple of pictures here to kind of illustrate different types of temperament. The little toddler on the left was actually our daughter Kate, who Stella congratulated us on when she threw a total tantrum after being very, very patient and quiet all day on a visit that we made to Alex and Stella. The picture on the right actually is Kate's daughter, Emma, and you can see from the looks of it, she looks like she has a very different kind of temperament. In fact, of course, they're both doing fine. I pulled out a couple of pictures of Bill at different conferences. This one was at OTC 2014 at the University of Nebraska. Many of you probably remember that occasion. Bill was always passionate about temperament, as you can see in this picture, but he was also interested and engaged in the OTC. He was really one of the, I would say almost the spiritual leaders of our group in OTC, and his memory continues to serve that function. So here is Bill's international diaspora. Charlie did a search on different articles using the infant temperament questionnaire, and you can see there are stars all over the map, including Africa, South America, Australia, China, and quite a lot in Europe. And a couple more slides to illustrate those trends. So the ITQ and the RITQ are shown here, the number of original published international reports by country, and you can see I counted them up, there are 22 different countries where these questionnaires were used. And you can see Italy is the winner. And we'll get back to that in just a minute. Bill had a special relationship with researchers in Italy and even the Italian language. He was very fond of speaking Italian. The ITQ and the RITQ publications by decades show that it reached sort of an apex in the 1990s and has declined ever since into the 2020s. We believe that is the result of the fact that actually it's not all bad. Bill and Sean's temperament questionnaires really became the foundation for other temperament questionnaires that perhaps had better psychometric qualities, but they continue to be an inspiration. And back to Italy, Vanna Axia, whom we lost a few years ago, very sadly, due to cancer, was what I call a friend of Bill. I don't know if you can see that in this slide. It's kind of off the screen. It's off the screen on my computer, but I hope you can see that. So here's just a few samples of some of the international research using Bill's temperament questionnaires. So Martin de Vries actually in 1984, published in 1984, coming out of some research that he did, I think in the 1970s when we were all in Kenya, did a study of infant temperament among the Maasai of the Kalahari, the Maasai of southern Kenya, and found that under severe ecological conditions, babies who were rated as difficult by their mothers had actually higher rates of survival than did easy babies, which was just the opposite of what he expected. But in seeing those data, which were very striking, I think there was a drought at that time and a lot of people died. Perhaps these, quote, difficult babies who were fussier, more active perhaps, maybe they demanded more attention from their caretakers, and maybe that contributed to their higher survival rate. Another study in Australia, a multicultural society by Keogh's, Pryor, Oberclade, and Demetrio, looked at cross-cultural studies of temperament in Greek infants and found that Greek infants living in Australia were generally considered more difficult than the Anglo-Australian infants on the dimensions of approach, adaptability, mood, and distractibility. There's another study actually also done by Ann Sanson and colleagues. I do not have a picture to show that, but among Aborigine children also in Australia. This paper I would love to see. I don't actually have direct access to some of these, but just looking at the abstracts, I thought this is one that I definitely want to read. Culture as a Context for Development, Suggestions from the Life Courses of Shy Swedes and Americans. And using a goodness of fit model, Kerr suggests that the cultural environment favors some temperamentally based behaviors over others, and the favored behaviors are then more likely to be associated with good developmental outcomes. So this is a picture I took actually of one of the little girls in our cross-cultural Swedish study. I don't think she's probably particularly shy, but just to kind of evoke the image of children in Sweden. And our own research certainly suggested that shyness, slow to warm up, low approach was pretty much expected, pretty normative among the families that we studied. So I'm going to hop over now to some of our own research, the International Study of Parents, Children, and Schools, which used the Carey and McDevitt temperament questionnaires And I like to particularly draw your attention to the lead investigators and their teams in the different countries. Giovanna Axia in Italy with Sabrina Bonacchini and Ugetta Moscardino, known as Betta. In Poland, Andrzej Eliasz with Olaf Zilic. In Australia, Harry McGurk, now sadly deceased, with Violet Collar. And in Spain, Jesus Palacios, and especially with the participation of Moises Rios Bermúdez and a team of other researchers. And in Sweden, Barbara Wells Nyström. So this was really a joint endeavor. As you can see, this is one of the happy occasions when many of us got together. Here's another one. You can see Vanna on the right at the bottom of the stairs, one of our grad students who did a lot of the Dutch research, holding her baby, and Jesus Palacios right behind her, Charlie up at the top. So a little bit about the study. It's based on 60 families in each site with focal children aged 6 months, 18 months, 3 years, 4 to 5 years, and 7 to 8 years. And we used for this study the RITQ, the TTS, the BSQ, and the MCTQ. So first thing we'd like to share with you is how we went from an EDIC, meaning US-based questionnaire to what is known as a derived EDIC questionnaire, which is generally more appropriate because it's based on the internal coherence of each of the dimensions in each of these cultural sites. And of course, there's more data that we can kind of provide as background, but this is just to show what happened when we made that survey of how well the items for each dimension hung together, and then decided, to include those where they hung together pretty well in at least 6 of our 7 samples. So you can see activity. The only scale that did not drop any items was approach. Intensity only dropped 2. And regularity actually dropped 5. And I think threshold, is it on here?
Yeah, it is at the bottom. For some
Okay.
reason, we have I don't know why we have.
Okay,
anyway.
so threshold only kept one item, and in fact, that turned out not to be so useful for us. So having done that, then we looked at the correlations of temperament dimensions, these different derived EDIC temperament dimensions, with how mothers rated their children as how difficult they are. And you can see, just glancing across this table with the names of the 7 different countries down the left, and the correlations that were significant or over 0.30 in all the different samples. And let me just summarize those findings in the next slide. So what we found generally is that in 4 of the 7 samples, children who were high in activity that was correlated with difficulty. Low adaptability seemed to be correlated with difficulty ratings in 6 of the 7 samples. Approach only in 1 sample. Intensity, high intensity in 2 samples. Negative mood in 6 samples of the 7. Low persistence in 3 of the samples. High distractibility in only 1 sample. And regularity and threshold were not associated significantly with ratings of difficulty in any culture. So looking at an illustration of this using multidimensional scaling, we can see for the Netherlands, here's a kind of typical presentation. So diff is difficulty, ratings of global difficulty, and then we have close to that persistence. So children in the Netherlands who were not persistent were more likely to be rated as difficulty. Children who were very active, children who were negative in mood and high in intensity and low in adaptability. So this is kind of a typical picture that we would see across almost all the samples. However, the Italian sample was strikingly different. Only adaptability, low adaptability, and low approach were correlated with difficulty. And if you look down at the bottom of this slide, you'll see mood has nothing to do with difficulty ratings. So these patterns of association mainly hold up with a sample of infants and toddlers, which we looked at later from the same cross-sectional study, but different kids. And most striking is the consistency of the Italian sample. You know what? I'm missing one slide. Negative mood is not associated with difficulty ratings. What happened to that Italian slide? Sorry. So Ivana's explanation of that was that children's negative mood is not a problem for Italian parents. What matters is emotional closeness. And now I'm going to see whether somehow the order of my slides got changed. But you can see in this table that the check marks are for traits, aspects of temperament that were related to difficulty ratings at both of the two ages. So on the left, we have infants and toddlers. On the right, we have older children. And I'm going to hand the presentation over to Charlie at this point. And he's going to talk about a later research that we've done. And I think
So-
you should
Yeah.
keep it this way.
So
we're
we
done.
put this last empirical slide in because it's something that was dear to Bill's heart, and it's a question that annoyed him every time I heard him talk, and that was it's starting from the very beginning. Some people complain that temperament ratings are just mother's perceptions. They're not really temperament, and it reflects the mother's state anxiety or trait anxiety or how her day went, it was bad hair day, whatever. And these data suggest that really is not the case, which of course Bill knew all along. There are three things measured here. The mother's satisfaction with the child's behavior on that day. We had 7 days of diaries of the child's day, and at the end the mother said, so how was it for you with the child? More or less satisfactory or problematic.
In various domains.
Yeah, it was summarized half a dozen questions about was this satisfactory, was that satisfactory? The same kind of measure of satisfaction with her own day. Her satisfaction with balancing childcare and work, satisfaction with her husband's responsibilities, etc. And you can see that overall, and this is from 6 of the 7 studies in the samples in the study that Sara was just mentioning. So this is a sample of a couple hundred. You can see that overall, satisfaction with the child's day is strongly correlated with this mother's satisfaction with her own day. That's not surprising, makes a lot of sense. It's true overall, there's no significant variation from sample to sample. We can also look at the satisfaction with the child's behavior averaged over a week and the mother's global difficulty rating on the BSQ. And we can see that on average, those are negatively correlated. The less satisfied she is with the child's behavior, the more likely she is to give the child a high difficulty rating. Again, no surprise. What's interesting is this varies by cultures. It's, quote, moderated by culture, being very strong in the US and not significant in Italy for the very reasons Sara talked about. What's new here, and this I think Bill would have appreciated, is that the mother's satisfaction with her own day is unrelated to her rating of the child's difficulty. And that's true overall in all the samples. There's no cultural variation. So I think this gives some credence to the idea, which Bill and many of us knew all along, that the mother's ratings really are her judgments about the child and her experience with the child, and it's not so much a reflection of her own issues. So overall, we want to end up just by summarizing that Bill's work, and of course he did this with various collaborators, including Sean and others, really was the basis for a lot of cross-cultural work. And his original scale was published in '72. Marty DeVries visited us in 1973 and brought the copy with us, and we said, wow, we got to do this. Cross-cultural research was really growing in that next 2 decades, And the Bill's scales were the foundation for the cross-cultural work in individual differences and the consequences for long-term development. So really, the successful adaptability, not to mention Bill's persistence, really are testimony to Bill's wisdom and his insights. Thank you.
Thank you, Charlie. It was very informative and interesting as usual. The work you do is so rich with cultural detail. It's always a joy to listen to it. Our next speakers are Mary Sheedy Kurcinka and Janet Crow. Mary is best known for coining the term spirited child and her publications and workbooks for helping families with spirited children. She's here today with her collaborator, Janet Crow, pediatrician from UCSD. They're going to be talking about infant temperament types and measuring infant caregiver stress. Mary and Janet?
Good morning. Janet and I are very excited to be talking about our project. We met through our common interest in temperament. And during a conversation I shared with her, I was working on a new book for parents of infants, spirited infants, because despite the excellent tools and training that has been done with pediatricians, these parents were, in my practice, I kept seeing parents experiencing high stress levels that wasn't being picked up and addressed in well baby checks. And so we decided to try and address that. And so the goals of the project were to effectively identify parents of spirited babies and to do so, again, with Bill's idea of simplification, to come up with a tool that was even faster, yet accurate, and could be used during a well baby check. And we also wanted to find a way to educate all parents of infants about temperament. And we did this because every year it's estimated 20 to 25% of babies born are wired to be highly alert and intense. And yet it seems that almost no one's talking about it. And that as a result, when these babies shift from calm to shrieking, parents often think it's something they're doing wrong or it's their fault. But we know there actually is considerable variability in children's temperament, and that variability can result in increased regulation and sleep issues, increased crying and shrieking, and fewer positive interactions. And this affects not only the baby, but the entire family. So we see increased marital stress. We see potential long-term challenges, behavior challenges for the child. We see that there's a greater demand on parents since these children are especially impacted by the sensitivity and skill of the adults in their lives. And yet it appears that most families are going up to at least 9 months before either seeking or receiving help. Janet?
Can you hear me now? Sorry.
Yes.
I did everything except unmute. Thank you for letting me be an outsider and a part of this talk. The purpose of our study was to explore the correlation between increased stress of parents and those temperament types described as spirited versus those that are spunky or low key. You may recognize these titles as work that Mary has done to put more of a more positive connotation for each of the temperament types. And so those were the titles that we used. With doing that, we wanted to create for all of the parents an understanding of the child's temperament so that they could begin to respond at an early age to the child's behaviors in ways that would affirm who they were. And finally, we're hoping by the end of the study to look at whether knowing about a child's temperament early may actually diminish a parent's stress level. And I'll tell you how we did that in a minute. We realized that we couldn't look at causation, but we were hoping to find at least some correlation. The study is being is taking place right now in our academic practice. We have a very busy academic practice that houses the block rotations for pediatric residents and third-year medical students, as well as a busy general academic pediatric practice. So we are offering at all 4-month and 9-month-old well visits the opportunity to take part in this study. If they choose to do so, they get a packet that has a 1-sheet page front and back. On the front has questions about the 9 temperament traits, and on the back, 5 questions about parent stress, as well as some demographic information. They get to take home a tip sheet for each of the 3 temperament types that we talked about, low key, spirited, and spunky. And at the 9-month visit, we're encouraging them, even if they've done it before, to do this again. The evaluation initially is to look at the percentage of infants with each of the temperament types to see if there is a correlation between temperament scores and caregiver stress, and hopefully by the end to see if there's any correlation between stress going down for those parents who were made aware of their child's temperament type early on. We did get approval from the UCSD IRB for the study.
So this was the infant temperament assessment. As you can see, the entire assessment fits on 1 sheet. We tried to synthesize the differentiating aspects of each trait, kind of looking at other questionnaires, and then also kind of practical language that I hear parents using during classes and consultations with them. Again, note all terms, we really tried to focus on descriptors and terms that were positive. In addition to the infant questionnaire, we did parent assessment, recognizing that parent stress levels vary potentially with the temperament. We looked at manageability, crying, feeding, sleep, and level of support, and how the parent perceived each of those in relation to their experience with their baby.
And then we asked a series of demographic questions that are somewhat standard for this type of interview.
And then in addition, we did a tip sheet providing information on all 3 of the temperament types. They're written in such a way to provide, first of all, information to help the parents understand each type. So for the low key baby, that their babies are mellow, and to enjoy that, and at the same time, effective tips. And the tips are written in the voice of the baby. I'm so mellow, my needs can be easily overlooked. And this again was intentional to create empathy and the recognition that through behavior, the babies are telling us what they need to thrive. With the spunky kids, it's a mix of traits. They're more intense than low key, but less than spirited, but usually have some trigger traits. So again, if I get upset in a crowd, please take me to a quiet place. I need a break. And then the spirited is that these children are intense and that every reaction, whether happy or sad, is strong and powerful. And that indeed, I need more help to calm. I need quiet for feeding and sleeping. And so again, that infant voice speaking directly to the parent.
So far we're about 9.5 months into our 12-month study. And so these are not our full statistics. We've so far been able to tally 184 surveys. You can see just in the bold that about 2/3 have been the 4-month visit surveys. Almost all of the people filling this out are moms. Almost all of the ones who filled it out are actually partnering with a parent or with a spouse or partner, parenting rather with a spouse or partner. And our age is skewed a little bit towards older moms, 30 on up, for the bulk of the people that participated in the survey. When you look at education, also a bit of a skew. The jump starts at some college and then into college and graduate, or college, graduate, and postgrad. It should be pointed out that a number of patients that come to our clinic are faculty children, as well as other people from the university. So that does put a bit of a skew, but not quite as much as what showed up in our numbers here. We've only had about 20 so far that have done the study twice, so we still don't know the numbers on that. Looking over at the right side column, on the far right are the San Diego County demographic statistics. We were a little bit low in our answer to Hispanic origin, fairly similar in African American, Native American, and Asian heritage, and then a little bit high in terms of our white race. So that was how our demographics came out compared to San Diego. So let's look at what we found. The number of babies that over on the far right that came out to be low key in our study were about 28%. The kiddos that were in the spunky, which would be slow to warm, and mixed trait kids were over 50%, and our spirited, or in the more traditional nomenclature, difficult kids were a little bit lowly represented at, or lower representation at 15%. Looking at this middle block, you'll see parent stress scores with comparison to the temperament type. So in your low-key babies, you've got mostly low stress parent scores, a little bit into moderate, none in the high. When you get to spunky, you see sort of a mix between low and moderate. And by the time you get to spirited, you're seeing more moderate and into the high. And it does look like there's a correlation. In fact, there is. So if you look at the Pearson's R for infant score to parent stress, with this brief questionnaire, we get something similar than that has been reported in the literature for other temperament questionnaires, and that there is a correlation between parent stress and infant scores. And if you actually look at the different traits, for the infant score, the traits that are, they're all very correlated, but intensity, sensitivity, persistence, and adaptability were the highest correlated traits. If you look at the traits that were most correlated with parent stress, it was intensity, sensitivity, and seriousness or mood. And then looking just at the parent stress score to see if we could tease out a couple of questions. Again, high correlation with all of them to the level of the parent stress, but particularly the question, which was, how often does your baby's crying cause you stress? And how often does your baby's lack of sleep cause you stress? And those two were definitely the highest correlated questions on the stress scale. So I think the strength so far of what we're seeing is that we are seeing a positive correlation between infant temperament score and parent stress with this shortened screen. The distribution of the temperament types are not too far off of what is seen using other measures. I will say, just in terms of the demographic summary and the limitations, 3 weeks into the start of the study, COVID hit. And we went from getting more than 50% or about 50% response rate to some weeks down to 10 or 15%. Really, really, I think affected parents' ability to think about doing one more thing. And I do wonder if some of those parents were the parents who have kids that are spirited. And just another thing in a tense, nervous environment may have not allowed them to participate in the study. I don't have any proof of that, but that's my suspicion. It would have been nice for us to look at parent temperament types, but it would have been hard to do it in the setting we were doing. And if I were to do this again or add on to it, I would do something for the parents to take home and send back to me. And then we didn't gather insurance information. It was an oversight on my part. In our clinic, we have 25% Medicaid, 25% military or TRICARE, and 50% private pay. I would have loved to have seen the breakdown in those different groups. So a couple of things from the parents that gave us feedback. One was a 9-month-old visit where I had twins, a girl and a boy. At the 12-month-old visit, mom immediately wanted to talk to me about the tip sheet and the temperament study, and just say it made such a huge difference to know that Zinnia, the little girl, is low key, Alexander is spirited, and they are both normal. And she just was celebrating the fact that she understood better. Little Grayson came in at his 4-month visit, had a cold, and mom had noticed some ear drainage that morning. In fact, he had a raging otitis media. His eardrum was perforated. Mom was just befuddled and trying to think, well, maybe he nursed a little bit more. He was a little bit less interactive. He never cried. He never was in pain. We looked at his temperament score. He was low key. Mom got the temperament sheet and said, this is going to be so helpful for us to think about things that we need to keep in mind for him, even if we don't think he's sick. So that was just a great reinforcement on the low end of the temperament. So as a busy practitioner in a teaching clinic, my sort of wish list to this group is to see if we can look at an even shorter validation of a temperament scale that can be used in a busy practice that will begin to look at these children very early and be able to be used in a well-visit setting. Also, maybe, and I think as Sara and Charlie pointed out, there may be even some shorter versions, and that's what we were looking at, that could be put into a template of an EMR for well-visit templates, and just ask those brief questions to kind of uncover those parents that might need a little bit more time. So I'm going to turn it back to, oh, before I say that, so PHQ-9 and PHQ-2, which are depression screens, have done just that. They have a 2-question study questionnaire that's been validated along with their 9-question validation that helps to look at depression. And I think we could look at something like that. I'd love to see that for temperament as well. Mary?
So as we bring this to a close, I think it's so critical that parents, especially of spirited infants, know they're not alone, that they need validation. They very well may be working harder. Their actions did not cause their baby to be more reactive. And by giving them information about temperament, that we can help them to see there's patterns that they can learn to recognize and help them to meet their baby's needs. And that there are ways in doing that to also care for themselves, because these babies will also synchronize to their stress levels. So like Janet said, we would really like to advocate that all of us continue looking for simplified, quick, accurate assessments that we can use in these teaching settings to bring that peace of mind and to build healthy relationships for the families. I also want to do a special call out to thank the parents in Janet's clinic who participated in this study. Thank you.
Thank you, Mary and Janet. Very interesting work, and I hope that your full results will be available soon. I was looking on the chat, and people are already asking for your tip sheets. So I think you're going to make an impact here, and good for you. Our next speaker is Dr. Cindy Ratekin from California State University at Chico. She's the professor of child development and chair of the department there. And she's going to be talking about temperament in the schools. Cindy was a student of Barbara Keogh, and Barbara was very much influenced by Bill, and is going to give us some interesting information about that. Cindy?
Thank you, Sean. Thanks everyone for the opportunity to speak today about Barbara Keogh. At the time of her passing at 94 years of age last year, Sean sent out a note to the Temperament Consortium, which summarized her accomplishments. So I thought today I would do a more personal side of my experiences with Barbara and the time that we spent together. I had the privilege of meeting Barbara Keogh in 1985 as I entered into the PhD program in educational psychology at UCLA. I was a member of the final cohort of her 40-year teaching career. I'll always remember my first class with her. Even though I had been a credentialed teacher and worked in the public and private system for many years, and although her legacy as a professor and a researcher preceded her, I was not quite prepared for the experience of being her student. The feelings ranged from, oh my gosh, what have I gotten myself into? Is it too late to withdraw from this program? This is going to be really hard, to complete awe at how much she seemed to know about everything. Her teaching style, which was comprised of asking difficult, thought-provoking questions to which she expected a response, her analytical approach, and her willingness to question the status quo, all those things took us students to a whole new level. Her commitment to creating life environments for children that respected their individual differences was her passion, and it was a life-changing experience for me. Barbara was first and foremost a clinical psychologist. She worked in multiple settings, including schools, probation offices, hospital clinics, and juvenile courts. During these experiences, she came into contact with many children who were struggling with life's expectations, and it became her passion to better understand and provide insight into what might produce a more positive outcome for them. She became a champion of children and families, seeing many ways for them to be successful by considering all the many aspects of the developmental process. One of Barbara's first areas of interest in typical children and children with developmental issues was in the area of spatial development. It was through this lens that she began to see many different ways that children can successfully approach an issue. After completing her doctoral program, she spent a year at the Center for Child Study at Birmingham University in England. And their multidisciplinary approach to looking at developmental issues became the foundation to her teaching and research. Upon returning to the States, she began her academic career at UCLA in the Department of Special Ed. Dr. Keogh became a political influencer. She worked on behalf of children with disabilities as a member of the United States Office of Education's National Advisory Committee on the Handicapped during the time when Public Law 94-142 came into play. This was in 1975. Also known as the Education for All Children Act, this law guaranteed a free, appropriate public education to each child with a disability. Public Law 94-142 had a dramatic positive impact on millions of children with disabilities in every state and each local community across the country. Over her career, Barbara continued to fight and to stand up for the educational rights of children with identified disabilities, challenging those who presented special ed as a solely cognitive issue and speaking to the No Child Left Behind Act as reasonable but arbitrary, with expectations that all children reach specific levels without saying how this is supposed to happen. And then Dr. Keogh came to temperament via her study of learning disabilities. In the early years, learning disabilities was primarily perceived as a discrepancy between aptitude and achievement. However, she suspected it was a broader and more complex issue. With her commitment to evidence-based programs, longitudinal research, and a multifaceted foundation to the study of child issues, in the late 1970s, Barbara and her colleagues established Project REACH, which over the years evolved into Project Child. This was established as a multidisciplinary team with researchers primarily based in anthropology, psychiatry, and special ed. Their objective was to investigate developmental delay in young children in the context of their families and consider the relationship to future learning and developmental issues to their initial developmental delay. The subjects were children under the age of 3 who were missing milestones in 2 or more areas without an established cause. They began with 37 children, expanded to 137 children, and followed the children and families for more than 25 years. What they discovered in part is that there were individual differences in the patterns of development over time, including their predictors and their outcomes. They found evidence that the majority of children delayed in multiple areas at age 3 continue to benefit from a broad range of expanded resources. The trajectory is not easily defined under one umbrella or addressed with a uniform intervention, such as a pharmaceutical approach. Additional critical findings in the study relate to the role of the families of children experiencing developmental delay. In contrast to much earlier approaches, there was no relationship between children experiencing developmental delays and problems within the families of these children. So you can see how the construct of temperament was such a natural fit for Barbara and her body of work. She was heavily influenced by the initial work of Stella Chess and Alexander Thomas. She shared their experience of being struck by compelling and powerful temperamental differences across her own 4 children. Their goodness of fit approach provided the scaffolding to make sense of the complex web of child development. Her operational definition of temperament was the interacting influence of genetics and experience on an individual's temperament-based characteristics. She posited that a reasonable generalization that can be drawn from different research groups is that genetic factors predispose individuals to particular patterns of temperament, not suggesting that temperament is immutable or that it cannot be modified. Rather, it suggests that these predispositions become actualized and expressed has to do with their developmental experience. Her areas of focus and temperament, no surprise, were the classroom and the family. Based on her early work in learning disabilities and the often utilized pharmaceutical approach to treatment, she had a long and enduring connection with Bill Carey, who in his role as a pediatrician shared the same treatment group. They also shared a commitment, along with Sean Mcdevitt, to the measurement and assessment of temperament, particularly the development of the short form of the teacher temperament questionnaire. Barbara was always interested in creating shorter forms. She consistently called for a more comprehensive and analytical statistical approach to address developmental issues combined with applied work, which was a position championed by Dr. Carey. Along with a handful of other temperament researchers, including Roy Martin and Jacqueline and Richard Lerner, the classroom setting was the focus of much of Barbara's research and many of her publications. She addressed multiple components of temperamental influences in the classroom setting, including students' temperament-based responses to school requirements, teachers' attributions about students. She was alarmed by the homogeneity in the context and the content within classroom structures, and she was fascinated with whole group versus an individual difference approach to teaching. Her research questions included areas such as, how does temperament contribute to teachers' interactions with students? How does awareness of individual differences in temperament allow teachers to anticipate where problems and conflicts may occur? And how does understanding temperament foster classroom management and interventions? Her position specific to the classroom was that an interactionist framework is important for understanding students' classroom experiences. Both children's and teachers' temperaments impact how effective classroom teaching practices are and the quality of the teacher-child interactions. Classroom management based on awareness of children's and teachers' temperament leads to an improved class and environment for all students. From this came her construct of teachability, a temperament approach for classroom teachers. Dr. Keogh had a great respect for classroom teachers. I remember being part of a group collecting data at a local elementary school. And as we finished the data collection process, we were asked to write a thank you letter to each teacher participating in the study and making sure to sign in blue ink so that it was clear that the letter was individually created for them as a token of her much appreciated participation. In her writings and research related to temperament issues with the family, Barbara also made a point of publishing in family-oriented journals, addressing questions such as, how can I help my child in school? Her response was that as a parent, you are the person who knows your child best. There are a number of ways you can help your child get along in school. Recognizing and helping your child understand his own temperament is the best place to start. Over the course of the 25 years of Project Child, temperament was added to a variable in the longitudinal study. In fact, this is where I collected the data for my doctoral dissertation, which related to the temperament characteristics of children with Down syndrome, who were matched to children with the undiagnosed developmental delay. I will always remember my first occasional temperament conference in 1990 in Scottsdale, Arizona, at the session organized by Sean and Nancy Melvin. I attended with Dr. Keogh, and I was so nervous. I presented my doctoral data and findings, and that is where I finally felt like a professional. This spring, I retired after a 30-year teaching career at Chico State. At this time of reflection, I have a new appreciation for how much Dr. Keogh has influenced not only my teaching and my work with children and their teachers and caregivers, but also my own child-rearing practices, and in turn, those of my family and friends and others who have sought out my opinion. Just last month, as I went to undergo a knee replacement surgery, the anesthesiologist was asking a few last-minute questions as I was about to be rolled into surgery when he learned I was a recently retired professor of child development. He immediately put down his clipboard and said, "Do you mind if I ask a few questions about my preschool age sons? I have some behaviors I'm concerned with." And I found myself responding as Dr. Keogh would have. And this is her legacy for me, an understanding of the role of individual differences and the premise that there are many ways to create a good life. Thank you.
Thank you, Cindy. It was great to have that kind of personal insight into Barbara's work and how she and Bill were on the same page about so many issues. I appreciate it. Our next speaker is Dr. Pat McGuire, developmental pediatrician with 30+ years of practice, now working as an author and speaker, raising awareness of temperament in her work as a lecturer. Pat?
Hello, I'm glad to be here. Well, I have to say that Bill and Sean and the other professionals that Bill worked with really kind of molded my practice in my 30+ years. It all started actually during residency, where I was a pediatric residency, and during a continuity clinic, which of course, that's what Janet was calling their academic pediatric practice. Our developmental pediatrician would have meetings with us every week, and he gave us this article, which was Chesson Thomas's Origin of Personality, 1970 Scientific American. That was my first introduction to temperament. I found it very interesting. Of course, it was just about infants. But about 2 years later, I had my first child, and I can only describe her as intense. Although I also say she was born with PMS. And I think Mary would understand that. That would become under the spirited child. Yeah, she definitely gave me a run for my money. And by the time she was 2, I was saying I either have to find a different style of parenting or just kill her, because I was starting to understand why parents would beat their kids. And that's when I found, because Mary's book didn't come out till the 90s, but Stan Turecki's book came out in 1985. I found it in 1987. And even just looking at his short checklist, it's like, oh yeah, that's my daughter. And so it helped me to be able to understand her more. My second child was what Mary and Jen would call the low-key child, because he was the antithesis of the oldest. And then my third child was probably the spunky child in the middle, because she definitely was a blend of the two. But this would help me to understand what was going on a lot more with her. And then it also, because that's when I also started my practice, was in 85. I got done with residency, started my practice in 85. It gave me common ground to talk with parents about if they had a child that was more stressful, more intense. And I really felt that helped me. And then I got involved in wanting to be a developmental pediatrician, but at that point, it was kind of like you could have a year at a university, or you could be in a physician's office. So I just started learning on my own, and I started picking up all this stuff on temperament and other issues. And then I began going to the Society for Developmental Peds meetings, and that's where I first met Bill. And he definitely was a character. He loved to talk to anybody who would listen about temperament. And he definitely, as Dr. Bob had said, he had a special feeling about ADHD versus temperament. But that got me interested in, okay, is there anything going on with that? And one thing that's in Bill's book, Bill and Sean's book, was the coping, what's it called? The coping of with children's temperament. He published it in 1995, and I actually won a copy of it at the Society for Developmental Peds in 1996, and Bill was gracious enough to sign it for me. And I used that as a basis for a lot of my practice. And there was a section in there about ADHD, and what they found was that there were 3 traits that seemed to be more common with ADHD kids, and it was a high activity level, low adaptability, and low persistence. So I found that interesting as I was working with kids, and I finally decided to start keeping track of what was going on with the kids I was seeing. Because in 1994, along with the publication of the DSM-4, Mark Walrick out of Vanderbilt developed the Vanderbilt DSM-4 checklist, which had all the criteria for ADHD inattention, ADHD impulsive and hyperactive, which together you could put ADHD combined, and then characteristics that would go along with oppositional defiant or conduct problems, which I basically lump under behavioral issues, and then characteristics that would go with anxious and depressed behavior, which I considered mood. And from there, I started asking my staff to keep track of the Vanderbilt checklist and the temperaments of kids. And from there, I was able for this presentation to do the most in-depth look I have at that. Because I started out back in about 2004, yeah, right. I did a presentation and I looked at 124 consecutive patients in my office, new patients. And we looked at, that was from March of 01 to November of 02. And looked at how many, and this is where you'd look at the DSM-4 checklist. This is the Vanderbilt checklist. Based on the checklist, if you only had that to diagnose, 88% of the kids coming to my office would be diagnosed with ADHD of some sort. 27% would be diagnosed with a behavioral disorder of some sort, and 30% would be diagnosed with a mood disorder of some sort. Now, when I actually did a full evaluation, I was a one-man shop, or actually two, because for a while I had a gal that had a bachelor's in psychology do some of the testing, and then I had a nurse practitioner. But basically, I did all the assessment. We did language, we did education. I did the ramble for some neuropsych, some memory and organization. We did the autism stuff, depending upon what was needed. So I did all of that. And at the end of it, it turned out only 31% actually came away with a diagnosis of ADHD. And that would be consistent with Bill feeling that people were over-labeling. I also found that although on the checklist, 27% were felt to have behavioral problems, in reality, only 14% would qualify under oppositional defiant or conduct disorder. And under mood issues, anxious and depressed, the checklist said it's about 30%, but it was actually 66%. Now, that's not surprising because when you think of these top two, a lot of times kids that are anxious will externalize and look like behavioral problems. They'll have a harder time with work completion and memory and organization, so they'll look ADHD. So that didn't surprise me either. And a lot of the kids I felt really were having more issues with anxious, more anxiety than depression, but more anxious kind of behaviors that was affecting how well they could function in their environments. So that was 124 kids. Then for this one, I actually was able to, to pull out, considering we moved 4 years ago, I was able to find this stuff and pull out 1,100, the charts are the data, not the whole charts, from 1,100 patients, new patients. And I found that when you divide it up, ADHD combined was 24% again of the DSM checklist, not a full diagnosis. 35.5% were inattention, 22.5 or 22.7% were impulsive, and no ADHD was 17.7. You put these three together, like I did here, and you get 82.3. So very close to my original 88% when I only had 124. So 10 times more patients, but the number was still very close. So, and this was from patients from 94 to 2016. And so it was all a long period, a long time span too. And it shows that people are still consistently over identifying kids as ADHD. Now, I don't have what their final diagnosis was because I wasn't asking my staff to do that. I wasn't thinking about that at the time. But what I did is I then looked at, out of those 1,100 people, I looked at 6 traits. The ones that are highlighted, rhythmicity, adaptability, persistence, and mood, are actually the traits that I presented at the 2014 OTC conference, looking at ADHD, behavior and mood issues. And for all three of those areas, these traits were elevated. And when I say +1, it's like +1 standard deviation, because I was still using the original checklist that Bill and Sean and others, so I've been using the same checklist from whenever I started getting it. Because you guys had some articles, I don't know if it was in Contemporary Peds or Peds Annals, but you wrote about them. Then you said, anyone who would like a copy, just write us, and and I use them all the way through. So it's very consistent on what tool I was using. So like +1 activity level would be a high activity level. Rhythmicity, more problems with rhythmicity, slower adaptability, low persistence, more distractible, and negative mood. And what you can see is indeed, even in the general population of kids I was seeing, those 4 traits were higher, which is not surprising because I was a clinical population, not a community population. But distractibility and activity level weren't as high. So that was my general population. Then I looked at, what I did is I talked to parents about because I'm going to look at, is it rhythmicity, persistence, and mood? I'm not sure. I'll have to go back. No, activity, adaptability, and mood I'm going to look at. But when you looked at rhythmicity, I didn't pull that out for some more data for you, but I found working with the families that rhythmicity, which the way I saw it dealt with, depending on age, the ability to feel time moving, ability to pick up cues of sequence patterns so you can be organized, all of that. I found that there were 2 groups talking to parents. One was totally oblivious of time moving around them. They had no awareness of patterns or sequence. More often than not, although I didn't record it, more often than not, those kids would have more issues that would be consistent with ADHD. Because the second group, they were aware that they didn't have a good handle and they couldn't feel time moving, but it bothered them. And so they kept looking for strategies and techniques that would allow them to stay organized on time. So they're the ones that, that probably developed half the planners and apps that we have nowadays to be able to keep track of what's going on. The other trait that I found had 2 subtypes was persistence. And one group, they needed constant stimulation to stay engaged. So they needed to make things fancier, funner. I remember there were kids that I would do the Peabody Picture Vocabulary Test with, and they would start wanting to sing the answers, or they would give a wrong answer, then immediately say, no, I mean, and then smile or laugh. So they needed to spice it up to stay engaged, stay persistent. Again, those kids, I didn't record it, but it seemed more often that they were the ones that would be identified by me as ADHD. The second group, they would get stuck. They'd be persisting, but they get stuck and they didn't know what to do next. They just stalled out. They had trouble moving on to the next one, or they just get frustrated or try to find something else to do that they could be successful at. Those kids really didn't appear to be ADHD because they knew they were stuck. They were trying to figure it out, or they were trying to do something they could be successful at. Spicing it up didn't make any difference to them. I did look at the numbers for, I can't see what's going here. For ADHD, I looked at the likelihood that ADHD combined would be present depending on what traits were elevated. So there were a total of 50 of my kids that were ADHD combined. 22 of them had all 6 of those traits elevated. 24 had all but distractibility elevated. Then we only had 3 where activity was not elevated, and 1 where persistence was not elevated. But if neither rhythmicity or adaptability were elevated, I didn't have any out of the 50 that were ADHD. But as you can see, pretty much you had to have all 6 of these, or at least 5 out of 6 to have people label you as ADHD combined. Again, that was a labeling, wasn't a diagnosis, because this is a very small percentage because you have, 46 out of 50. What I found is, rhythmicity and adaptability were, the traits that were found across all 4 of the ones. And so that, that was important. And of course, what did Bill say originally that they had? They had, let's see, they had high activity level, low adaptability, and low persistence. So persistence was on here, but it was missing with that one. But adaptability seemed to be a big one. Activity level, except for, again, a lower one. But these 2 traits had to be seen by most people for them to say they thought their child had ADHD. When I looked at this just by percentages, 23.5% of kids that did not meet the DSM-4 criteria of ADHD had high activity level, 38% were non-persistent, and 37% were negative mood. If you looked at all types of ADHD together, you can see that it was much higher in the ADHD group for these problems. And it didn't matter, there wasn't one type of ADHD that was higher than the rest, because when you look at it, inattention, you wouldn't see the high activity level, but you would see that, especially for mood, it was pretty consistent with these guys that mood was negative mood in about 1 out of 5. Again, inattention group was more non-persistent, so they needed to be engaged, whereas the combined group, they needed more activity. So, there was some differences, but definitely the high activity was not seen in the inattention group, which is a smaller group of kids. You have impulsive, and then you have combined, and that's 71%. But it was consistent that different traits of temperament would explain the behaviors in many of these kids. And I think that's important when we work with them, because that's what I would do with families, is I would look at the traits, discuss the traits, and then explain why ADHD was or was not found, because it wasn't just the temperament traits or the checklist. It was a combination of that and environmental factors like learning problems, other neurodevelopmental issues, but also, poverty, domestic abuse, child abuse, all those issues that would affect. So definitely, bringing in the temperament traits helped a lot and helped them understand, especially if I did not find ADHD, even though they or the school were concerned about ADHD. I could say that's these traits that are mimicking. And if you work on the trait, you can improve the child's, behavior and attention. And parents were very, very positive about that. Schools, it kind of depended upon their own individual mindset, as I'm sure that educators in this area know. So, but that was important. And then I also just looked at the CDC side on children's mental health to see, what are comorbid problems, because those are the ones that I think, as I saw with the original chart, 66% turned out to have mood issues. Well, this is now this is diagnosed by the CDC. They were using those numbers. So for ADHD, 9%, were considered ADHD. 52% also had behavior problems like oppositional defiant conduct, and a third had anxiety. 17% had depression. If you look at behavior problems, the biggest comorbid was anxiety and depression. I didn't put ADHD in here because it may not be the same as this, because some things they don't go back and forth as easily. Anxiety and depression, behavior problems can be very common. You look at a lot of ODD kids, and a foundation for them is anxiety issues. And also a third of them had co-depression. So, you'd say this kid is a behavioral problem, but their issues may be more anxiety, depression. And the same with depression. It's a smaller percentage of the population, but behavior problems, again, are seen a lot, and anxiety is seen a lot. So it's important to realize that, we have to look beyond checklists. We have to understand the child. That's where the temperament comes in, and being able to explain, well, the child's more anxious and depressed or acting out more because we're having a problem with fit, understanding why the child does what he does. And that's basically how I ran my practice for 30 years. And I had a lot of parents that were very happy about it. And I've also had a lot of kids that were very happy about that. Like one teenage girl, her mother brought her in because she was such a behavioral problem and they were always fighting. And mother was an educator and was on track to become a principal. And the daughter says, I'm not going to come back for any more of these sessions. And I said, well, how about if your mom comes and then maybe after about a month, you come back and tell me how she's doing. And what I did during that month, I saw her once a week, we talked about temperament and how temperament was influencing how they interacted. And the mother was very open to learning about this. And, you know, we talked about strategies and all that. So a month later, the girl came back in and I said, well, how's your mom doing? Oh, I don't know what you told her, but she's a different person. Yeah. So this mother who then became a principal, I mean, she started bringing the idea of temperament into the school, talking with her teachers about it because she'd seen such a difference just with her own child. And a lot of children, when I would go through the temperament profile with them, they would say, yeah, that's me, or, you know, and the parents would agree. I would say that I used all the ones that they had from, well, basically because you need Vanderbilts, it had to be 3 and above. I did kind of break Bill's rule because I used the middle childhood temperament questionnaire beyond age 12 because we didn't have anything beyond age 12. So I kept using it through high school. And I only had a couple of parents who said, this doesn't, you know, fit my child. It seems too young or something. The majority, you know, vast majority, I think it probably had, you know, less than a dozen parents that didn't agree to it. And when I go over and explain the traits to them, they would still agree with, you know, how they had rated it. And the student would agree with how it had been rated. So I feel that, you know, that questionnaire, you know, maybe there are a few tweaks in there, but overall, I think it's valid all the way through high school because both parents and children or teens felt that it did describe them. But it helped them also understand themselves more and how to work with each other. So that's what, you know, Bill and Sean gave to me. Now, I've only made, this will be my second temperament conference. The first one was in 2014. And as you can see, I had to get a picture of Bill and Sean. Now, back up here in the corner is someone I think that we're going to be presenting on today or giving an acknowledgement to, Helen Neville, right up there in the corner. So it was great that I was able to get her snuck in. I'm not sure. I think this guy was from Poland. I'm not sure, Sean, do you know who that is?
Yes, I believe he was from Poland.
Okay. So, you know, it's like,
his name, but he's from Poland.
Okay. But he seemed to enjoy the temperament. I know, you know, all of us did. And I was very glad I was able to get this picture of the two of you since, you know, I will never be able to do that again. So nowadays what I do is I have a website, and I apologize to Diane. She had me review stuff and I didn't realize that I had not changed my website because on the agenda still says allchildrenarespecal.com. I recently closed that down and now I have helpingchallengingchildren.online. So people can look at that, and I have my email. I also have a podcast, and it's called Helping Challenging Children. And you can find it, I have it housed at Buzzsprout, but you can find it on most, you know, pods, you know, like Apple and Spotify and Pandora, you name it, you can find it there. I'm going to be starting my second season pretty soon because I took a break in the middle of the summer because of the COVID stuff was just driving me crazy. So I'm going to start a second season, but that's pretty much how, you know, Bill's efforts and Sean's efforts really influenced my entire career and got me looking at, you know, especially ADHD and understanding that the traits can give us some clues how the child's, you know, functioning and how to help without even needing a diagnosis of ADHD, because most of the time it's not an accurate diagnosis. It's a checklist diagnosis.
Okay, thanks, Pat. It's a really nice presentation. I think it's clear now from your data and evidence elsewhere that there's much more to ADHD than temperament. And I think, you know, people like Dr. Bob are on target by looking at some of the executive function issues that a lot of these kids have. And that if we're lucky, somewhere down the road, the definition will change to include other factors than just the ones that are there now.
Yeah, I'm wondering it with that, because I forgot I was going to bring that up when he was talking about that. I'm wondering if rhythmicity and sensory threshold play a role in that. Because at one point I was teasing some of that out, but I never went very far. But that may be something that, Bob wants to look at.
Okay. Well, we're going to have time for a discussion, hopefully, at the end of the presentation. I'm going to do my talk now, and then we're going to have the Crystal Award. So let's see if we can kind of get through this quickly enough that we'll have time to do that. I'm going to talk about comprehensive behavioral assessment and management. 50 years ago, Bill Carey created the first temperament questionnaire in the modern era. It replaced the lengthy semi-structured interview used in the original New York longitudinal study. His paper was published in a pediatrics journal. The infant temperament questionnaire was a quick, inexpensive caregiver survey that could be completed in just a few minutes. Bill had been intrigued by the findings of Thomas and Chess in New York and was one of the first to see the potential for using temperament in primary care. Anyone who's ever used a temperament questionnaire is in some small way following Bill's footsteps. But creating the infant temperament questionnaire was just the beginning. A private practitioner, Bill worked independently to develop his own clinical methods for utilizing temperament. I had the incredible good fortune to meet Bill in 1975 and to work with him for over the next 45 years. Bill's efforts gradually evolved into defining a comprehensive model for dealing with child behavioral issues. This model positioned temperament in its rightful place next to other elements affecting child behavior. The road to achieving this goal is a subject that will be discussed here today. To see how Bill's perspective developed over time, it's useful to look at the trajectory of his career. There were some major milestones along the way. To illustrate the range of his professional activities, I've listed them here roughly according to time. 1970, created the first temperament questionnaire. From 1975 to 1982, the 5 questionnaires now known as the Carey temperament scales were created or revised, covering the entire period from 1 month of age until the end of the 12th year. Bill and I worked together with colleagues at Temple University, Robin Hegbick, Bill Fillard, and Barbara Medoff-Cooper, to create this series of questionnaires that measured each of the 9 NYLS temperament dimensions. In 1995, Bill published Coping with Children's Temperament, a guide for professionals. Coping was a book that reviewed the existing literature on temperament research and applications. It was intended to educate professionals in clinical practice on temperament information and methods over the period of infancy and childhood. From 1997 to 2005, Bill wrote and revised Understanding Your Child's Temperament, a book for caregivers that outlined common temperament issues and possible solutions. Bill's book for parents and other caregivers drew directly from his pediatric practice, and he shared much of his practical knowledge with the public. 1998 to 2004, Bill spoke out against the conceptual and pharmacological problems with the widespread ADHD diagnosis that pathologized temperament in some children and labeled them as abnormal. Fighting against the overuse of the ADHD diagnosis by medical professionals in the United States, Bill was highly critical of the practice of giving stimulant medication based solely on brief caregiver descriptions of behavior. Normal temperament and simple conduct problems were being labeled as ADHD, a more serious neurodevelopmental disorder. In 2004, we developed the Basics Behavioral Adjustment Scale. It measured behavioral adjustment in 4 to 14-year-olds. This rating scale specifically distinguished temperament from behavioral and interpersonal problems, a significant issue at the time with the existing ADHD formulation. Most behavioral adjustment scales are checklists of problem behaviors or symptoms of psychological disorders. Bill saw the need for an adjustment measure that was qualitative, strength-based, and that covered all the major domains of function. The Basics, a 48-item caregiver rating scale, was developed to assess these areas and was included in his overall scheme for assessment of behavioral status. 2009 to 2016, Bill developed and refined an algorithm for clinical decision-making about behavioral concerns to determine whether a presenting problem was temperament-related and how to assess and manage the issues identified, whether temperament was involved or not. Bill formalized this tool that provided guidance for professionals assessing child behavior. The goal was to distinguish simple behavior problems from temperament or adjustment problems or behavioral health conditions. From 1983 to 2009, Bill was an editor of the textbook Developmental-Behavioral Pediatrics. This volume was used as a primary source of knowledge for pediatric residents and included several chapters on child development topics. Over time, Bill rose from being an associate editor to senior editor of this major textbook, widely used in pediatric training programs. Today, I will highlight some of the features of the clinical model, behavioral assessment, and intervention developed over the course of Bill's career. The book illustrated in this slide is the last one Bill published on temperament and assessment and management. It represents the endpoint of his thinking on clinical practice, and its essence was captured in a decision-making tree that was included in both editions of the book. The tree represents a complex but practical way of assessing child behavior for use by professionals from many different disciplines who work with typically developing children in their specific settings. By the way, this book is available free of charge in PDF format as a download at the link listed here. Here's the algorithm. No need to try to decipher it. I'll explain it in a minute. Clinical practice and research follow different patterns. Researchers generally select a problem to study and then narrow the focus of their inquiry until they can gain the precision they need to obtain meaningful results. Practitioners, on the other hand, are usually presented with a narrowly defined behavioral issue that can often be only resolved by developing a broader and more complex picture of the interaction. This frequently involves including or excluding a large number of factors along the way. The algorithm at the left directs the investigative process, determining the presence, absence, and severity of the issues that are uncovered. Bill's rationale for creating a detailed algorithm is explained in the following quote. Having determined that there is some cause for concern about a child's behavior, emotion, or functional well-being, the clinician can then proceed in a systematic way to obtain the information necessary to achieve a diagnostic understanding that supports appropriate care. Unprepared clinicians often feel helpless at this point and may unnecessarily seek ways to dispose of the situation as quickly as possible, using one of the dodge, quick fix, or immediate referral strategies. A well-defined map assists clinicians to move forward in behavioral assessment rather than find ways to avoid doing so. Here schematically are the main steps in the algorithm. It starts with defining the main concern. The process begins with an expression of concern about behavior, or more rarely, a concern on the part of the professional based on history or direct observation. Step 2, clarify the goals. Does the caregiver want to be helped? Or are they just venting frustration? Or is it something they want to work on with the professional's input? If yes, proceed. If no, express concern and monitor the situation. If there are any concerns about child safety, take the appropriate action. Number 3, determine other behavioral problems or adjustment concerns. Use the basic dimensions of adjustment and define whether there are other specific behaviors that should be considered. Number 4, rule out physical, neurological, or cognitive problems. Could there be a medical cause, a neurological issue, or a learning problem? If so, evaluate or refer for evaluation. Number 5, determine whether a main concern is behavior or another management, such as problems such as parent inexperience or misperceptions. Number 6, if it's a behavior problem and severe, refer immediately for mental health assessment and treatment. Number 7, with mild or moderate problems, determine whether temperament is part of the issue. Number 8, if the problem involves a temperament-environment interaction, evaluate temperament, and discuss and modify the interaction through temperament counseling. If not, assess other child environment factors, stress in the family from conflict with the child or parenting difficulties. Provide caregiver consultation. Number 10, discuss other psychosocial factors, physical, cognitive, or environmental. Number 11, provide psychosocial intervention and support. Modify factors including education and improve goodness of fit. While this algorithm is very useful in its schematic form, it lacks sufficient detail to explain some of the choice points that clinicians need to make it effective. The next 3 slides will illustrate in more depth Bill's methods for evaluating behavioral adjustment and doing temperament assessment and temperament counseling. Here are the 6 dimensions of behavioral adjustment developed to indicate how well a youngster is functioning in their current situation. The positive attributes are listed on the left, and the problem behaviors are listed on the right. I'm not going to go through all of this in total detail, but I'm going to hit the highlights. The first dimension is behavioral competence in social relationships. This involves social skills, success in having relationships, caring, cooperation, involvement, reliance. Youngsters who do not have good behavioral competence have negative adjustments indicators like under-socialization, aggression, opposition, and withdrawal. The second major area is achievement. Positive signs, test performance, and mastery at home, school, and community. High or sufficient achievement, effort, motivation, and satisfaction. Poor adjustment indicators include poor achievement or failure or excessive preoccupation with work or play. The third area is self-relations. Positive signs, self-assurance, self-esteem about academics, social worth, appearance, physical abilities. Poor adjustment indicators, poor self-esteem, poor body image, self-neglect, risk-taking, over-concern for oneself. The fourth area is internal state, expressed feelings and thinking. Positive signs are reasonable contentment and clarity of thought. Poor adjustment indicators include over-control, inhibition, or under control and impulsivity. Also, anxiety, depression, or thought disturbance. The fifth area is coping or problem-solving patterns. Positive signs are being able to identify problems, plan solutions, and work on them persistently, revise them when needed, and get help for solutions that are not working. Poor adjustment indicators include ineffective or maladaptive problem solving with excessive use of denial, avoidance, or repression. And finally, the sixth area is symptoms of physical function. We're looking for comfortable function in these areas. Poor adjustment includes moderate or severe problems in eating, sleep, elimination, unexplained physical complaints, and repetitive behaviors. Let's talk about temperament assessment. Stella Chess used to say, everyone believes in the environment until they've had their second child. She was right, because the most common concern we hear about temperament is that the child is not acting like another child or the siblings at home. Caregivers are often worried that they are doing something wrong and may be damaging their child who behaves differently. At one time, there was a belief that temperament should be assessed in all children, but experience has shown that it's only necessary when a temperament concern is observed or expressed. Here are the basic steps recommended for temperament assessment. When obtaining information from the primary caregiver about child behavior, listen for expression of concern about behavioral style. For example, the sensitive child parent will say, she won't wear her socks because they're too scratchy. Or with a non-adjustable child, they'll say, I can't get him to stop what he's doing to come to dinner. Number 2, follow up with interviewing about behavioral style issues to see whether other temperament factors could be involved besides the ones expressed. Number 3, whenever practical, directly observe the child and engage them in an interaction to get direct evidence about their behavior. Number 4, if several areas of conflict emerge, use a temperament questionnaire to organize the caregiver's observations of and opinions about the youngster's temperament. On to management. There are 3 levels of management of temperament based on how pervasively they're affecting the child's interaction with the environment. Unlike behavioral or adjustment issues where we seek to change the behavior, the main focus is on identifying and accommodating temperament to improve goodness of fit. Level 1 is simple education about the existence of temperament and how temperament can affect behavior. Just explaining what temperament is and how it influences the child can allay feelings of anxiety and guilt in caregivers by providing an accurate explanation for the patterns that they're observing. Level 2, discussion of the significant ways that temperament may be affecting the child's interactions now and providing general suggestions for accommodation. Temperament counseling at this level can help the caregiver tune into the child's individuality and obtain practical information about how to accommodate it. Level 3, an intervention plan can be created using an individual temperament profile and outline a series of changes in how situations involving temperament environment conflict are handled so that goodness of fit can be improved. This may require several contacts to implement and refine the plan to ensure that it's effective in reducing conflict. Looking at Bill's contributions as a whole, there's no doubt that his influence on the field of temperament and child behavior has been enormous. I'm proud to have played a part in his work and know that his presence will be greatly missed in the temperament community. Finally, no discussion of Bill Carey's work is complete without repeating his ongoing call to professionals, and especially researchers, to assist clinicians in the further development and evaluation of temperament applications for the benefit of children. This involvement is needed now as much as ever.